Live stream's going. We did the recording.
Now, Jeremy, this meeting will be on YouTube, right? And our Facebook, so
It's
that.
streaming. It's streaming now. It's Facebook's. No, it's not. It's not on Facebook. It's on YouTube.
Alrighty, I would like everyone to introduce themselves. I'm Sandra Unger, Chair of the Health and Human Services.
Rich Reynoso, member.
Bernadette Ferrara, Chair of Community Board 11, member, and
Doug Cutler, Chief of GI at Jacoby and North Central Browns.
Right. We know, do I have to read the conduct
No, I don't.
statement? I don't think so. They all know.
I think you should.
Okay, yeah. That's
All right,
fine.
okay.
Every single time
Yeah.
you do it.
Okay, so now
Sorry,
I'm
that's
going
fine.
to read the conduct statement. Community Board 11 meetings must be held in a professional and hassle-free environment. The following rules of conduct are applicable to members of the public Community Board 11 and the Community Board staff. Any action or behavior that disrupts or interferes with Community Board 11 business will not be tolerated during any Community Board meeting and may result in the individual or individuals being asked to leave if the action or behavior continues. This may be considered disturbing the peace and the appropriate authorities may be summoned. If the meeting is held remotely, the person may be muted or expelled for the remainder. Repeated violations of the same person or group of people may result in further action by the community board. Any public speakers must address the full board or the committee with their concerns. Electioneering for a position other than officer of Community Board 11 is prohibited. Engaging in acts of violence, including threats, are grounds for immediate suspension of the right to attend meetings pending review by the Ethics and Disciplinary Committee. Respect the equality, diversity, and privacy of all persons by respecting and valuating differences of culture and opinion. Refrain from unpleasant or disparaging remarks or other actions. Abstain from all forms of harassment by actively discouraging it. Disseminating false information is prohibited. All right. The minutes were sent via the email and they should be accepted. Dr. Coulter, it's all yours.
So I sent along some slides. Are they going to be shown?
You have access to your email?
Did you send it to Jeremy?
They were
Who did you
sent
send it to?
John Doyle.
Let me see. I don't.
Yes, Jeremy.
Jeremy. Uh-oh.
Let me see. Are they on there on the drive?
Yeah.
Yeah, they should be. You're good.
That's why we need a test person.
There's a thing there. Just a bit. It's restricted. Go, it's in the file. You'll see it when you once I pop it up, you'll see it, right?
There it is. Select to choose what happens. So now what are we gonna do?
You tell me where to go.
Go to ways, state modified most recent.
Okay. I got 319.
How about nursing grandparents?
This one?
Still wrong.
It's all good.
Hey, we didn't notice
This
this.
is a biology major. You can take it, you can have it, presented it this way.
Okay.
About a couple of weeks ago, one of the slides was the basis for an op-ed piece in the Bronx Times.
Oh, wow.
Oh, great.
So let me just view here and make it big. 1 second. Slide master. No, it's not it.
Here. Get that.
There you go. So I'm going to share the content with everyone. You can see it online.
Thank God he's here.
No worries, no worries. All right. So
I'm not-
this one. Okay, share. Perfect. Just tell me when to.
I'll tell you what the.
Yep. To
Okay,
So, thank you very much for inviting me.
and thank you for coming.
I will tell you that about 52 years ago, as a second-year medical student, I lived on Van Ness,
Oh,
about a block down, corner house,
I'm in by the.
almost set the place on fire. Trying to do something with candles in, I haven't tried to cook anything since. In any case, after finishing my training at Einstein and then Jacobi, and then training more elsewhere, and then being downtown at St. Luke's, I came back 8 years ago to be chief of GI at Jacobi, and I'm happy I did. All right. What I'm going to show you is some slides, about 20 minutes worth. I hope that's enough.
It's fine.
For colorectal cancer, and I've titled it Local Realities, because I want to tell you about what happens with us, not what happens in the whole world, but what happens here in the Bronx, 10461. Okay, I have the first slide, second slide. Now, I'm going to be saying sort of the same stuff over and over again. I apologize. This is just a general introduction. Colorectal cancer is common. Fourth most common cancer, second most common leading cause of cancer death. And the important thing about it is that there are a number of misconceptions. And I'll get to those in a minute because I don't want to be droning on. But the best time to find it is before people feel it. That's the whole idea about screening. We've actually done pretty well in that the incidence of cancer has gone down.
For colorectal.
Colorectal, yes. Has gone down especially in the older age groups. But it's not because of what we've done in the older age groups, but what we've done in the somewhat younger age groups to prevent things from going on older. But sort of the improvement is it's like stopped, it's lagged. We haven't gotten to where we have to get. Don't need that. Next slide.
Okay.
So for when you get the quiz at the end, let me give you a little bit of an overview. And then I'm going to talk to you about what we did at Jacobi, and mostly about what we can do to prevent people from having advanced cancer. Be nice to prevent people from having colon cancer, all right? But if we can't do that, and you'll hear why at Jacobi, why we can't do that, the least we can do is try to keep people from coming in with incurable cancer.
Yeah,
Advanced
too late. Yeah, late stage.
You know, if you need surgery, you need surgery. If you need chemotherapy, you need chemotherapy, but at least stay alive. Right? And then I'm going to talk about our initiative and another initiative, which is like not colonoscopy. Breaks my heart as a gastroenterologist, but I'll get over it. But it's for testing stool. And then the last
Oh, like
thing-
Cologuard, I'm sorry, like
like
Cologuard.
Cologuard or something called FIT, which is a whole lot cheaper. And then I want to ask for your help, all right? Because I'm a doc, okay? And you could say that and I'm a gastroenterologist. So you could say I have a conflict of interest, you know? The more people I do scoping on, the more money I make, but that's not the point of it, okay? Especially working in a place like Jacobi, but that's not the point of it. The point of it is to try to keep people from dying of colon cancer. Next slide. So there are a number of misconceptions. I want to go through these. Not now. I put this in case I had 5 minutes because this would be my one slide. So there are several misconceptions. One is that people think the problems with colon cancer are getting worse. And they're not getting worse, they're getting better, but they sort of plateaued. We want to take it a step further. The second is that, it happens in young people. That's where it's really bad in young people. But that's not really true. You hear a lot about it ever since Black Panther, right?
That's
Right?
what
Chadwick Boseman, right?
Oh,
And
okay.
all right, that sort of brought it to the forefront. But the older you are, the more likely you are to get colon cancer unless you get screened. The third is, what can you do about it? It's like in your genes, you inherit it. That's also not true. There are a couple of colon cancer families in which everybody gets it. Just like with sickle cell disease, if you get the 2 sickle cell genes, you're going to get sick. But for colon cancer, that's really uncommon. And most of the time, it's something in the environment And if more people are getting colon cancer now, it's not because our genes are changed, it's because the environment has changed. I think everybody would agree with that, the chemicals and such, the environment. The fourth is that, well, if you just stay healthy, that's all you need. But if you feel good, then why bother doing anything? That's a real misconception. I mean, it's good to not smoke, and it's good to maintain good weight, it's good to, you know what I mean, to get exercise. But if you're gonna get colon cancer, you're gonna get colon cancer unless you do something active to prevent it. And the fifth thing, which is the hardest one, is that, well, you can either do a stool test, like Cologuard, or something called a FIT, which is cheaper, or you do a colonoscopy. But that's not really true. Because if you do a Cologuard and it's positive,
You have to get
then
the
you do a
colon.
colonoscopy. So it's really like a two-step procedure. And for most of the people, you do a screening test, which is not the biggest, most expensive, most bothersome thing. You start with something simple and then see who's at the highest risk. And then you do a colonoscopy to figure out exactly where it is, exactly what it looks like, right? Tell the surgeon that's where you gotta go. Don't let them go exploring like people did 50 years ago. Open you up wide and go like putting their arms in there and looking around. That's like, I mean, that was good 50 years ago, but we should be more precise than that. Next slide. So these are the rates of colon cancer for the last 40 years. You see, they've gone down. They've gone down in men, they've gone down in women. And they've gone down because of screening. The screening started really right around here. But this is the important point here, the important 2 points. If you find colon cancer by doing a screening test in somebody who has no symptoms related to colon cancer, the chance of a cure, they talk about 5 years survival, but it's really a cure. It's really 90% or more. On the other hand, if you come in and you're sick, you have some symptoms, and it turns out those symptoms are due to colon cancer, that's 20% or less. So, right, so the time to find it is to find it in its terminal state, which is before you feel it, not afterwards. So the whole idea that, well, why should I have a test? I feel okay. Is like a bogus, it's like a bogus test. It's a bogus.
I think.
So screening has become good, but about a quarter of the eligible people don't get screened. Maybe it's up almost maybe a third, but it's a lot of people. Next slide. So this kind of says it all. These are data from about 10 years ago, 7, 8 years ago in Jacoby. 60-some cases of colon cancer over a year. Stage 0 is sort of like the earliest stage. Some people would even say it's not cancer. Stage 1 is that it's real cancer, but hasn't really gone anywhere. Stage 2 is that it's invaded into the intestinal wall, but hasn't gone through. Stage 3, it's gone through and is involving the lymph nodes, the glands outside. And stage 4 is it's in the liver, it's in the lungs, it's widespread. For people who underwent screening, 94% of the people at Jacoby, well, Jacoby and North Central Bronx, 94% very early. But for the people who had a diagnostic test, meaning they were bleeding or their bowels had changed or they were losing weight or they were had new pain, something that makes you worry, 51% already had cancer that's gone beyond the colon.
Yeah, they even had my son take it early because his father had.
Right, and that increases the risk by about 80% or maybe doubles the risk. It doesn't make it automatic,
Understood.
but sort of the higher your risk, the more people should look. The lower the risk, maybe the less we can get away looking. Although we're not very good at doing that, other than to say, you know, if a first degree relative at it, you know, there's no test that you put in that says, oh, you're gonna have it.
Yeah, no.
So
Next slide.
what is the screening, what does the screening entail before the colonoscopy? So I don't know if you're gonna get to
The
that.
colonoscopy is the screening.
Oh, that is?
Yeah, he just.
I mean,
said
the, I mean, the
two-
preparation, you mean the stuff that you have to take to clean out.
You still have to, yeah, you still have to take that, right?
Yeah, because unless you get a good look at the colon, you can't see what's on the wall. You can't see.
Oh, okay, got it.
Okay, so these are the data about colon cancer in young people. Okay? The blue is under age 50. The green is between ages 50 and 64, and these are people 65 and older. 65 and older, 75 and older, or sort of everybody over 65. And you can see that the older you are, the higher the numbers of cases. These numbers, you can't see that they're getting better, they're getting higher, but they are. And this stopped 6 years ago, so it's actually gone on board since then. But the relative number, as a percentage, has gone way up because the number of the older people has come down. And it didn't come down for something that was done at age 75. It came down because of things that you did at age 50 that prevented the cancer at age 65 or 70 or 75. Next slide. So these are the things that you can say will increase the risk. Well, older you are, certainly, certain countries. Yeah, there's some hereditary syndromes in which everybody gets it, but those are pretty rare. If you have like ulcerative colitis or Crohn's disease or chronic inflammation, well, that increases cancer risk, just like cigarette smoking gives you inflammation in your lungs to do the same thing. And well, if you eat a lot of meat, or let's say you had cervical cancer, you got radiation therapy, or you eat a lot of fat, or obese, or smoking, or drinking, you see the relative risk. It's not all that high. And then things that are protected. Well, physical activity is protected. A high fiber diet is protected. More fruits and vegetables, which probably means less red meat,
Yeah.
is protected. For women, hormone replacement therapy is protected for the colon.
Yeah, but they stopped using Premarin for the hormone.
Because of other.
Yeah, I know.
Well, this is all really nice.
So
And what does this have to do with Jacoby? Okay, next slide.
Yes.
So I don't know, maybe 4 or 5 years ago, a group of trainees, a group of residents came and said they wanted to do some research. They wanted to study colon cancer and colon cancer prevention. And I'm chief of GI, so how can I say no? That's what we're there for. Professor at Einstein. This is like,
it was a good idea.
yeah, and they deserve everything if it helps them to go further even more.
Mm.
So our setting is what's called the safety net hospital. You know what?
Is that-
All right, safety net, well, if you call 911,
They come to
that's
you.
where you go.
So is it fair to say, what's this kind of dark graphic, but if you get shot in the Bronx, there's only a couple of places you can go.
It's
You mean
like-
for trauma?
It's a trauma center, exactly.
Yeah, like St. Barnabas. Jacoby.
Lincoln.
Yeah, like, okay, yeah.
But
It's like they used to say about Mount Sinai, that if you like got shot right outside the emergency room at Mount Sinai, the resident would come out, look at you, they would call 911.
Get out.
And right, and then the ambulance will come and take it like fine.
My goodness.
Or the same thing with Tisch Hospital in Bellevue. But that's okay. But what it really means, a safety net hospital is that you have two kinds of patients. You have what are called continuity patients. And working class people come there, that's their clinic, that's their clinic doc. And then there's the non-continuity patients, and you don't see them unless they get sick. Somebody at the, Morningside Nursing Home or Kings Harbor, or just somebody who's living, that doesn't have insurance. Well, you don't see them unless they.
unless they
get
have to
sick.
be there, yeah.
Which means that if you're going to see them when they have colon cancer, you see them
It's
once
probably
they're already
late.
sick,
Yeah.
which means that they're not going to do well. That's the problem.
Jacoby, excuse me, Jacoby is still for 24/7, isn't it, for all 5 boroughs, the trauma center?
Oh, yeah, just
Yeah.
like the,
Do they have the
It's like the bird-
helicopter? Do they have the
I think
helicopter?
so. Well, we don't
Yeah.
get those very
Oh, really?
much,
Yeah, I'm
But
just
they're
saying,
also-
growing up,
Also for burns or. for
Yeah, they are
everybody.
famous.
burn
The
trauma,
hyperbolic
Yeah.
trainer,
Oh, really? Wow.
yeah.
yeah, Jacoby is famous for that.
It's actually, they're expanding it. It's going to be the biggest in the city.
Wow, yeah, but I know, yeah.
Means more patience.
So this is what, well, yeah, it's also hyperbaric chamber for people out in the ocean who get the bends from like, right?
Yeah.
Coming up to.
Coming up
Oh.
from there.
So what we decided to do was to look at the characteristics of the colon cancer patients, what made them come in with advanced disease, and we looked at all those things that were on the slide before, about smoking, drinking, weed, whatever we could find in the chart. So half of the patients were our patients, half of them came from outside. Only a minority of cases were located for screening. And for the people who had them, very small number had prior screening colonoscopies. And it turns out that's not really very much different than the experience in the rest of the country. We all suck.
Mm.
Well, just like I showed you in that other slide,
Look away.
the minority of patients in the screening were advanced, whereas the majority of the ones in the diagnostic.
Hmm.
But here, we weren't looking at 60 patients, we were looking at 340 patients. And when we did this statistical analysis to find out how important was diabetes and how important was cigarette smoking and how important was obesity and how important, none of them were important. The only two things that were important is whether you were a clinic patient or not. Because if you weren't a clinic patient,
You didn't get all
you didn't get screened. How's somebody without insurance going to get screened? Who's going to screen them?
Yeah.
Who's going to send them, you know? So isn't the lesson is that we got to find those people?
Mhm.
Okay. And the other is not only continuity, but once you are a continuity patient, did you actually get screened?
How do you gonna
Only-
find that? How are you gonna find the patients that are not continuity patients?
It's
You
only when
gotta
they
go
come
down.
in.
All right.
Okay,
And maybe I'll jump ahead because I probably won't have a chance to talk about it very much, but like, how many people do you think live in NYCHA housing?
A lot.
Thousands and
it's
thousands.
everywhere.
I know, yeah.
750,000 or so when you're talking about it, maybe 50% are over age 50. Well, what percent of those people lack insurance or lack a good doc? I don't know, but we can't ask it at Jacoby.
Mm.
You gotta go to the NYCHA housing and ask it. You gotta set up a health fair there.
Yeah.
You gotta have people come.
Health fair. I was-
But we're having that.
I was just thinking that.
Fair.
Yeah, when she said we're having a health fair.
At Bronx House, all the
I
people
was at
of
Brown's house 2 weeks ago.
Well,
But-
this-
Now you have to come back.
For the
Now I gotta go
community board.
back. Right, and in fact, I presented this to the nurses.
Oh, really?
Well, this is the test, this is their.
Oh, yeah, yeah, yeah.
And they said, we'll help. And I'm working with a community group. And the important part of the community group is that there are a small number of people who get paid and the others are volunteers. And that's what we're really hoping for, is to get volunteers from the housing who are gonna help their neighbors.
Well, yeah,
And not
because
only are we gonna do it for colon cancer, we're gonna do it for another thing, frailty. What happens to the elderly when you stop going out? and you
Oh, I
stop
see.
eating?
oh, you gotta come to the health fair.
You have to.
You
You
really,
gotta
you
go
really do,
to a table and whatever you want.
So, yeah, so
and a presentation.
go back to John Doyle.
Oh, I will speak to
Okay.
John, yes.
Right, next
We
slide.
know each
Okay.
other on
Okay.
multiple levels.
No, it's
So this compares Jacoby and NCD to something called the SEER database. And the SEER database is about half the country. And if you look, it's sort of like, right, the age ranges look kind of the same. Maybe in the Bronx, there were fewer really older people, but the lifespan here is shorter than in much of the rest of the country. Though there are probably fewer people, you know,
To clarify, what does SEER mean?
SEER
SEER, yep.
is a national database.
Okay, the national database compared to Jacoby. Okay, got it.
And here, Jacoby has a few more women than men, SEER database, a few more men than women, but not great differences. Next slide.
Yeah.
All right. This is the racial group. At Jacoby and NCD, 75% are Black or Hispanic. In the SEER database, maybe it's only about half.
Oh,
Yeah, but where it's the multitude of the population of the Hispanic and Black, you know, but
Countrywide.
Yeah.
Countrywide.
Yeah.
And then you look at the disease stage. And Jacoby had sort of fewer, the very localized compared to the others. But when you get to distant, this is the disease that's in the liver when we start out. Here it's 21%, here it's 21%.
yeah.
Interesting.
Not different.
Not
Interesting.
different,
Not
yeah.
different. So Jacoby may be a safety net hospital. Jacoby may be serving some poor people, but like
but they get
these
good
guys,
care.
they do it so great, you know? And then it's lastly unstaged. I like people who come in from the nursing home and they're so sick and they're so far gone that they don't even go and try to figure it out because there's just no way they're gonna get better.
Mhm.
And you know what? Jacoby has a bunch, but so do the rest of the country. They also have a bunch. We ain't the only place with nursing homes. Right?
True.
And we ain't the only place with nursing homes in which people don't get the best of care.
Hmm.
Right, next slide. So, as I said before, you can look at me, you can point at me and say, you know, you have a conflict of interest. You're a gastroenterologist, you want to do colon cancer screening.
Yeah.
Well, the AGA, which is the National GI, they have a bigger, right? They have even a bigger conflict of interest, and yet they came out saying, you know, one side doesn't fit all. If a quarter or a third of patients don't have any kind of screening, and we really want to get on top of this problem, we can't just rely on screening colonoscopy. We have to develop the non-invasive tests. We have to do better at it. The stool-based test for blood or the stool-based test for the genes, the Cologuard, the box with legs.
Yeah, I know, yeah.
We have to improve risk assessment. Because really, there are people who need to be screened more often than they're being screened now. And there are others who don't need to be screened quite as often. And if we can figure that out, we might be able to do better. And then this is the last part. And this is really where we fall down. As they said, shared decision making. You got to bring the patient in and get the patient to understand what it is you're doing and have them make the choice.
But that's why when you have a patient coming in, there should be someone with them to help them with that decision making, be it a child or someone else who could also guide them.
Mhm.
You can't send them in alone,
Well,
you know,
yeah,
what,
that's true.
because they don't always hear what they want to hear.
That's a
or
good
should
point.
hear.
That's a good
But
point.
at the same time, if you don't give the information,
Yeah, but that's why
a
you
real
have,
problem with modern medicine. You're sitting and doing so much on the computer, you have about a minute to
Hmm.
actually talk to somebody,
Oh, I see what you're saying.
right?
yeah, yeah.
You've got to figure out a different way to do it, and I'm going to show you at the end two versions of what could be done, right? But I think this is what's important. I think this is what we're seeing the most. This is going to be hard. This
Education
gonna
is
be hard.
always the first.
Education.
Right.
Yeah.
It really is.
So that,
And, you know, a lot of people, when they get, oh, colonoscopy.
so this is the most important slide.
Really.
Okay, and this comes from a health group called Kaiser Permanente.
Yeah, but
You may have heard of Kaiser Family Foundation or whatever. I think Kaiser was aluminum or something, some rich guy. But he did good. And they did they've been doing it for the last 20 years or so, a ongoing study, an ongoing initiative, mostly education for the first 5-6 years. And then you see that the number of people who are getting screened went up and up and up and up and up. So their percent up to date when they started was 40%. By 2018, it was 83%. It was way better than the national average. And at the same time, the incidence of colon cancer went down. The incidence of dying from colon cancer went down. And of the colon cancers they found, more of them were early cases and less of them were advanced cases.
That's a
yeah,
good
but that's,
formula.
it's important. It really is.
But then you take this side. And then here they compared non-Hispanic whites to non-Hispanic blacks. That they had to be non-Hispanic is like sort of a science thing. Like, it's okay. They had enough of those so they could do. They looked at early cancers, late cancers, all cancers, and dying of cancer. And the red are the non-Hispanic blacks, and the blue are the non-Hispanic whites. And you can see that for much of the time, the numbers in the blacks were higher than the numbers in the whites. You know what that's called?
No,
That's called a health disparity.
Yeah,
Just
Why?
right off the bat,
Just
that.
yeah.
Just that.
Looking at the data, more in one group than another is a disparity.
These are people who are the same age.
Same age,
Mm.
same doctors,
Yep.
same clinics, right?
But
Or look
why?
up on the screen and look at the
Yeah,
different.
but why?
Yeah, no, the why, yeah.
Well, does it matter why, or does it matter what you can do to make that go away?
Well, I think it's both.
Because look here, look all the way over at the right, 2018. Two lines have crossed.
So they kind
What
of,
was
they
the
made up,
disparity
they made up.
is gone. And what did they do? They educated people,
Yep.
right? They offered the people a choice. You want a colonoscopy? Yeah, we'll do a colonoscopy. You have to do a colonoscopy. You don't want to do a colonoscopy? We'll do a stool test.
Which is not as invasive, obviously.
Right.
yeah.
Right, you
Just
start,
under-
you
as
start
long as you
small.
know
Yeah.
that if the stool test is positive,
You have to.
then you really need a colonoscopy.
Right.
Right,
And do you get them to agree to that? Do they, say, okay, if it comes back positive, then I'll get the regular
I
colonoscopy?
guess they did,
Yes,
I guess
yeah.
they met up at the end of 2018.
Yeah.
And then,
Yeah.
so then the last question, well, then how do you do that? How do you do that education? And when I asked them, they were a little bit like, we're not telling you. You know what I mean? It's like, oh, well, that's okay. We talked a lot.
This is Kaiser?
This guy.
Of course, yeah.
Yeah.
All right, next slide.
Okay.
All right,
You know
so
what,
this,
Sheila?
so this is our experience with FIT. This is the stool test.
Mm-hmm.
This is the cheap one. That's a,
I never heard of it.
all right. Fluorescent immunochemical test.
I've heard of it, but it doesn't seem to be as accessible as Cologuard to
No, it's,
the primary cares, to the primary cares.
we get them and just hand them out.
Huh.
Which is the problem, because we should get them, hand them out, and educate the person. Right? So this is how we first did it. All right, just getting it and handing it out. 2,400 specimens were submitted. Probably 7, 8, 9,000 were actually given to people.
Yeah, how did you
10% were
keep track of that? If you gave out, how do you keep track if they, what?
Because they have to send it in, and that's their name. And therefore they know, and actually the city knows,
Okay,
because that's all centralized, and we get a report every month.
got it.
Because if they're positive, not only do they need a colonoscopy, they need a colonoscopy right away.
Mm.
If you wait too long and it really is cancer, by the time you get around to it,
And
It's too late, or it's,
if we wait too long, then we lose the benefit, because then if there's a cancer, it may spread.
Mm.
But 70% were positive. All right, we ordered a colonoscopy of 80%. 20%, we didn't get that done. And the ones that we did, only about half actually went through it. So it means that we were down to a pretty low percentage. Now, the ones we actually got done, the risk of finding a colon cancer was 50 times higher.
Wow.
The risk of finding a polyp of the type that is very likely to turn into cancer was about 4 times higher. So you could look at that and say, what a great job we did in the people that we actually did, did the colonoscopy on. Now, you could also look at it the other way and said, how many cancers did we miss? How many cancers did we actually have a chance to find them? And by the way, most of these cancers were, so they were curable, because the patient didn't have any symptoms. It's not like they were bleeding. Well,
Yeah.
it's not like they could see that they were bleeding, but there was a minute amount of blood in the stool. Yeah, it could have been a hemorrhoid, it could have been,
Yes, something small.
but it's the kind that if you drank cow's blood, you wouldn't get a positive test, because the test looks at human blood.
Interesting.
And we then went further into the chart. Said, well, why would people put in a stool test and then not have a colonoscopy? Is it something we did, or is it something we didn't do? Almost 80% was the patient refused. which means they must not have understood
Oh, I see that now, okay.
Yeah,
what the implication,
Oh, I see.
and what we didn't do.
that's why
is we
sometimes,
didn't educate.
that's why you always need an advocate with you. Because, you know, if say it's in Hispanic and they don't speak English
Yeah.
that well, they're not gonna understand.
Mhm.
So therefore, the interpreter or whatever would help them, or a
We
family.
have telephone translators.
Okay, well, I'm just,
Yeah, but you're making the appropriate point. It's like we can't stop where we are. We've got to do better. Next slide.
Yep.
So now I need you
you'll,
to.
we'll get it.
Now you're gonna, yeah.
So the city has come out with their version of what we should do to educate the patient. Next slide. Yep. It's a comic book.
Oh, you can hand them out at the,
Yeah, you can hand them out, but it's a comic book. We're talking about something which is life or death.
Yeah. I see what you're saying. Even that, I mean, even you guys, you might not even take it seriously because it's a comic book. Yeah.
And the city says, well, we don't want to scare people,
True.
right?
You should kind of.
yeah, but if you don't, you don't take it away.
Yeah. And where the city can say, well, you know, there are a lot of people who are illiterate. So how can you give them a big book?
Oh, I see.
They're not even gonna read it.
But the information is pretty good. This
Good
was like,
questions.
this was like the first slide I showed. This is like the second or third slide from the next slide.
What is
This
this?
talks about the symptoms. This talks about early cancers are curable, and late cancers.
Do you have it in several different languages?
18 languages.
Wow. Okay.
All right. But then when they get to the point about, you know, if the stool test is positive, you need a colonoscopy. It's right here. If blood is found in your sample, you might need a colonoscopy. What is that? That's like,
That means you need one.
yeah, it's like.
It should,
it
the
should
next
be
step
involved,
is,
yeah, with exclamation points. And
It shouldn't say might,
No,
it should say you will need a colonoscopy.
call your doctor.
Call your doctor.
Call your doctor, but see
Then-
that might,
No,
it
no,
gives you that
The
out.
doctor's gonna call you.
You
Because the
will,
doctor gets the result.
Mm.
right,
And that's
right.
the point. When we get the result from the primary care chief,
Mhm.
it's up to us, the navigators, to go out and find these people
Yeah.
and then try to convince them. Right, next slide. But then they have this, you know, that one little sentence, and then here they have, well, you eat green vegetables, exercise, keep your weight down, quit smoking, you know, don't drink alcohol. That's all like wellness,
Yeah.
and it's absolutely good for you.
But it's not gonna
But it's not
stop
gonna-
the cancer from
it's not
spreading.
gonna stop the cancer.
All right.
So I have a different way. This is what I want to know from you is whether my different way goes too far the other way. And it's the way that I approach my patients when I go to get consent for the procedure. I start by saying, there are a lot of people who say, why should I have this procedure if I feel okay? And the reason is if you feel okay and, you know, if you have a cancer, you're going to get cured. If you wait till you get symptoms, you're not going to get cured. Same thing I said to you. The risk gets higher as we get older. They start from benign. And if we can actually find them when they're benign, we can prevent the cancer, not just find it when early, but we can prevent it. Next slide.
Yep.
And then this could be shorter, but you know, the two ways of doing it, stool test, or screening colonoscopy, there's a blood test that's coming. But as good as that sounds, it may not be so good because we might not be able to prevent. It may just be an early diagnosis. But that's, you know, let it come here and let's move and then see. But to prepare for the colonoscopy, you got to change your diet. You got to take a Bordante, you know, you
Yeah.
got to really get cleaned out so we can see what's going on. You probably should have to, you know, quit like hard vegetables like broccoli and cauliflower and beans and such, corn. Bravely do a colonoscopy and you see, you know, like,
Yeah.
you know.
Well, the corn never,
Yeah,
ever.
yeah.
Comes out
that-
the
that-
same
See
way
it
it
in
goes
your
out.
own, yeah.
Always, you know, anyway. And then you might think this is really gonna like hurt, you're gonna be embarrassed, you're gonna be anxious, but you know, we give you medication. Either just to sedate you, which is used up, or sometimes if that's too hard, we have to knock you out. And we have trouble because we don't have anesthesiologists to do it. Montefiore does, we don't, but we get through that most of the time with not a real problem. And then there's the stool test, but if it's positive, really need it. There's not a choice. It's not one or the other.
Eventually you will need it, right?
Right.
It's like no matter what,
If you're positive.
delaying the time doesn't.
Right, delaying the time makes it work.
If
Yeah,
the
like-
food test is negative, you're good for a year. If a colonoscopy is negative, you're good for 10,
Okay.
all right?
Oh, so that means I should, okay.
So, do I have anything else? Yeah, I got one more slide.
Okay.
And that's the point.
Okay,
Any test is better than no test. And the test you have, that's the best test.
So you're saying that the one colonoscopy is kind of good for 10 years?
Unless you find polyps.
Unless something
And
happens.
that means your risk is up, because if you've had a polyp,
right.
you're at risk for having more.
Yeah.
So if you have one, well, then you've got to have it in
Every-
5 years.
Every 5 years.
If you have 3 or 4 or 5,
My brother has to get it every year. He's gotten quite a few.
well, yeah, if it's really quite a few, every time you look, you find more.
Yeah, and I did the Cologuard. I've had both.
But there's always,
No, I should
but
take
there is always that risk for somebody taking advantage and doing too much.
Right.
Right, and I can't say it's not, because
I think he does it every 2 years.
Yeah.
Every 2 years. I take that back. But I just know that,
so the 2 points are, how do we get this education to the people, number one? Which is like talking to the doctors and the nurses at Jacoby and NCD, but the other is, how do we get it to the people who just don't happen to have a doctor? There's nothing wrong with the people, they just don't have insurance, they don't have a doctor.
But
That's
don't they have Medicare or Medicaid?
They may not. They may be undocumented.
Yeah, and then they're afraid to go to doctors because then they're
That would
afraid.
be it, afraid, right. But at Jacoby, you don't. And if you are undocumented and you need something like colonoscopy, you get emergency Medicaid, which is not having somebody paying for you forever, but just for that procedure.
Yeah,
It's like a
but-
life-saving procedure because we're a safety net hospital, as much as if you were hit by a car and you got brought into the emergency room.
Yeah, they gotta
Right,
give you the
right.
right
We
emergency.
have to take care of you. We can say the same thing for screening colonoscopy. We
What?
can't say it for a nose job, right?
Right.
Well, we can say that for a colonoscopy.
So what's the, you go ahead.
my question is, in, where is it, the nurses, wherever the town hall is or the auditorium? Why
The
not,
rotunda?
the rotunda, thank you, I couldn't think of the name, the rotunda,
In Jacoby,
yeah, okay,
why
why
can't we
not,
do it there?
why not, why not have, like a lecture hall?
Well, we did it there. We did it there last month,
Oh, okay,
right? But if you don't go to Jacoby,
You don't know.
then how would you know to go there? On
uh,
the other hand, if you lived in NYCHA housing,
but also,
every one of those buildings has like this common place
Like
where
a
you would have,
community-
where you would set up your health fair, where
Yeah.
they would have a Zumba class, right? And
right,
they would have Tai Chi,
well,
where they would do all
The
these
community
things.
center.
Yeah,
well, you have
why can't
Eastchester
you do it at Brown's
Gardens.
house?
What, well, also Eastchester Gardens is, it's close to the NYCHA houses, right? So that's, part of Community Board 11.
Yeah, that is.
So,
Marty, isn't Eastchester Gardens water brand shop?
I think so. One of our board members, Keith Ramsey, represents that area. So he would be a person to speak to see about, that's exactly where is that?
Well, we went to the health fair, but we're gonna have our health fair at Bronx
Oh,
House.
so you're gonna have a Bronx house, but there's been other health fairs
Yes.
over at,
Different groups, but we would love it, and I will let John know that you presented, and it was what was really good is you spoke that we understood.
what's your phone
You
number?
didn't give us, what's, medical,
Can I give you my cell
medical,
number?
doesn't give us, all that medical mumbo jumbo. You're talking to us straight out,
Yeah.
it's understandable. And that's what makes it so good.
But you could also ask people, how many people have had a colonoscopy, how many people have not? Or sit here and ask them, why, how many people went with their primary care? And ask the 2 or 3 questions or give out a survey.
Thank you.
So wait, but what do you think about what I showed you?
Your presentation?
One way, no, not the
No,
presentation.
your.
The booklet,
The comic book
Yeah,
versus
I think it should
looking
be
him in
more
the eye,
serious. I think it should,
looking him in the eye and saying, this is serious stuff. This is as serious as a heart attack.
yeah.
This is as serious as a stroke. this is as serious as.
Well, you should have those as headlines. I worked in advertising, okay? So something, whatever you need to hit, like, this is serious, like what you just said would make my eyebrows go, okay, I think I need to listen. Okay, and then you can maybe incorporate the simple graphic, those simple graphics are easier for people to grasp, okay? So I understand why they're done, but there's a point where it gets serious. And maybe it's a big stop sign, or it's like, you stop here. Because at this point, it's no more fun and games. This is what you have to do. So,
Thank you, Richard.
Yeah.
do you think that you could send it to Jeremy?
Presentation.
Or
Yeah.
the presentation?
Yeah.
John Doyle-
Yeah, well, it's gonna be on,
Okay.
I could not upload it from my computer when John sent
We'll
it
ask,
to me.
we'll ask.
Wait.
Will it?
Can you put it in? and
It's,
then
but
download
it's,
it?
but it's been on, it's been.
No, because I
recorded.
can't
You
send
can't
it,
download it?
I can't send the file in the chat.
Ask John Doyle to send it to Jeremy.
Yeah, and then we can
I'll-
disseminate it.
Give me the guys,
Email?
email and I'll send it.
At what age should you get screened? What's the earliest
I
age?
think-
Because folks are gonna ask.
Now it's 45.
So
45.
45. so,
Yeah,
okay.
But as you see, it really goes up and you start early. And I would think that the earlier you start, the more likely you should be doing stool testing.
But a lot of doctors, like my son went for his test because his father, my former, had colon
Then
cancer.
they say you start 5 to 10 years.
Yeah, so they,
Or the colon cancer in your family.
Oh, really?
Right,
Okay.
yeah.
Right?
So-
Because, if your grandma had it when she was 95,
Yeah.
it's different than when your older brother had it, when it's like 48.
Mhm.
Okay, and the older you are with the cancer, typically the less vicious the cancer is.
well, they say
When you
some,
get it when you're very young, they're often incredibly vicious cancers. And we've seen some in like 25-year-olds, 30-year-olds.
Really?
Not
Yeah.
many, but
They-
some.
they say
They're
that,
horrible,
that sometimes
but,
people die from a cancer they don't even know they had.
right.
When, like, and then when the autopsy is done, they find it.
But those are really.
Yeah, yeah.
They say they're more common now than they used to be. All right.
But folks are getting screened more.
No, but those, they show up in the hospital when it's.
Yeah.
Oh, really?
See, yeah,
Because you're never going to screen somebody at age 25
Yeah.
unless they have one of these genetic syndromes. But then it would be everyone in the family.
and it also depends on your healthcare and your providers and who you have. My son worked for HSS, who is for the federal government, so,
Yeah.
Does insurance cover the fit tests?
yeah.
Okay, like primary care annual.
Oh,
No, 'cause folks may not know that. Maybe
Yeah,
people,
well.
folks
that-
may not go because they don't.
That actually is important.
Yeah,
because,
good question.
I mean, that's why even people without Medicaid get emergency Medicaid. It's because they mandated that the federal government the federal government mandated that insurance must cover these preventive health screenings.
Right, as much as.
So mammograms, pap
Years
smears,
are all covered.
colonoscopy screening, every one of those. And it's like a big bill.
Yeah,
I gave a talk, not this talk, but a similar talk to a group of physicians in Nigeria.
Oh, wow.
Something called Project Echo,
Mhm.
which actually started in New Mexico when they were doing hepatitis testing and treatment for doctors in big cities talking to the doctors on Indian reservations or way out in the boondocks where they didn't have a lot of medical expertise. And it was a way of bringing that expertise there. So they tried to do the same thing with colon cancer screening in Nigeria. Now, Nigeria is huge.
Yeah.
yeah, it's
180 million people or something. And a lot of money, a lot of corruption. The money doesn't flow down.
Yeah, that's a,
So, just as an example, the head nurse in the GI unit's brother just died of colon cancer.
Really?
But there's no screening. Nobody will pay for it. And if you happen to be a, a hotshot in the oil industry, well, if you want to get treatment or you want to get prevention, you fly to London. But if you happen to live in Nigeria, you don't. And if you happen to be a bank clerk or somebody, a middle-class person, ain't no screening. And there's very little insurance. And if you do have insurance, the government does not mandate that insurance has to cover it.
Unlike here, what they do.
Here they
Yeah,
do.
see, a lot of people complained about Obamacare, so to speak, but he really got all this going.
Right.
And called for all that, to be
And people
covered.
say, oh, that's socialism.
Yeah, yeah.
It's not. It's like
It's
basic
all
human,
prevention.
it's basic human rights.
Mm,
Right.
yeah, good healthcare.
Good health.
What do you think about, I mean, how does something like this deal with, like in the UK and Canada, they have,
Same thing.
Yeah.
They have that, all healthcare is subsidized by the government.
Yeah,
okay,
There is no Blue Cross Blue Shield of like Birmingham, England.
no,
It
because
is
they
the
have,
National Health Service.
yeah, they have national might, yeah, so I'm just wondering, but is it offered, I mean, is it across the board, is it offered to everybody?
And in fact,
but
they
you may have to
started,
wait
they-
longer.
right, and they
for-
started doing the stool testing there before the US started. We kept on with colonoscopy.
Mm,
They had more trouble sort of like getting the colonoscopies done. So they started doing stool testing earlier. And since the government was paying for everything, you see, we have private insurance.
yeah,
The government says you have to cover it. They're not saying we have to cover it, they're saying you have to cover it. Now, they do for Medicaid, Medicare, et cetera. But in essence, they're telling private insurance that they have to cover it.
mm,
And they
okay,
can't say no
well, it's because of it's federally based,
Because of what, yeah,
because it's a mandate.
it's a
Yeah.
mandate.
it's a good mandate.
But I must say, to change this, that your presentation to the point and understandable. And that's the important thing. Not all this, some of them come with these terms and these all medical things, and you don't know what's going on.
I think the charts are really good to show
Yeah.
what's been done like 30 years before and how it was preventative, how it did change.
And I think the important point is that our experience is no different than everybody else's.
Yeah,
Now, I guess if you're a rich person and
well,
you're
that's,
getting screened and you're getting screened too much, well, you're probably gonna do better. And you're gonna do better with heart disease, you're gonna do better with lung disease, you're gonna do better with a lot of stuff. But for the people who actually take part, well, then you do pretty much as well as anybody else.
we have a question in the,
Is it, yeah?
Someone asks, is Cologuard worth it? Should people skip Cologuard and simply consult a gastroenterologist?
That's a choice. That's a
Herbert,
choice.
it's a choice.
If
Oh.
you wanted to just have a colonoscopy. I mean, I've had colonoscopies.
Yeah.
I've had colonoscopies. My wife has had colonoscopies.
Yeah, I've
Fine.
had both, but now you reminded me the next time I go for my annual physical, I'll remind the doctor last year, I should take another.
So what do you do? Well, I said, what do you do if you're 45? And the risk of having colon cancer is really very low. Well, that might be a time to do a stool test.
Yeah,
How about if you're 82 and undergoing colonoscopy may be a little risky?
yeah.
You're 82, you've had a couple of heart attacks, you have some heart failure, you have some
And
lung
you got your
disease, right?
anesthesia.
Right, and you're an anesthesia risk. Well, people like that might do well to have
The fit or the
a
colon.
stool test. And then if they're positive, well, then they shouldn't have, the colonoscopy at the Hutch. You know what I mean? Some little ambulatory endoscopy center, then it should be in the hospital
In
with
case
an
something happens.
anesthesiologist under the best of, well,
as best as
but I
you
think
could.
that's stuff that has to be worked out to try to optimize how we take care of people.
Mhm. He said, thank you.
He thanked you for your input.
So this will be on YouTube, so we'll let folks know to come and watch this. It was very, very good, very informative.
Yeah.
I learned a lot.
Thank you.
Yeah.
And thank you
No,
for the tech.
no, yeah, it's definitely good, definitely.
I didn't curse or anything.
No, you're good.
No,
But you're on
it's-
YouTube forever, I'm kidding.
But outreach is always an issue.
Yeah.
Outreach, I don't care if you're a community board or you're like a small civic association. It is an issue from the time that you start. How do you get to enough people? So you hit the nail on it. The NYCHU buildings, just like Co-op City, I'm telling you, every one of those buildings has a tenant association.
Every building, wow.
In
Yeah,
Co-op City?
yeah, or, and they have, and I know this, when they want to get the word out, they get the word out.
Well,
So-
in any co-op, there was a tenant association, so I could see it for every building.
Yeah, so
Wow.
this is, maybe in conjunction with our health committee here, it could be something that
Yeah. I
can
mean,
go out.
It'd be a nice thing to show it and show the rest of the world how it should be done.
You can get a little portable projector. They have the little portable projectors now. They're only about that big. Bring that with you. You got a wall. You can show things right there, answer questions. It can be very, very, low key. Saves any kind of like,
And if you can do this, well, then you can do blood pressure,
yeah,
right?
that's right.
But that's for cardiologists, right?
Yeah,
Hey, look.
Or you could do frail,
Mhm.
that's
because that's the hidden,
I never would have thought of that.
frailty is, I've fallen and I can't get up.
Yes,
Frailty is when I was in training, the old Jewish lady on Pelham Parkway and White Plains Road who took a bath and then was too weak to get out of the bathtub
Mhm.
and then lay in the bathtub for days
get out.
until the girl from upstairs who would go shopping for her would come down.
that was really a case? I never, wow.
Over and over and over.
Wow, over and over. So repeat cases of that happening.
Oh,
And
yeah.
I'm sure that still happens.
Yeah, I'm sure people
That's
don't.
why
That's
it's always a good thing to check on. See.
Now that my kids go, okay, take a phone into the bathroom. Wait,
Just in case.
you go down to the
It's
My father had the life alert.
Life alert.
And I'll tell you, that was the best thing. Because even though he was only a block away from my house, that was him and my mom's choice. Don't ask me why, but they were a block away. I said, Dad, mom's gone now. I said, you gotta have this. I said, unless you wanna lay on the floor, scream and nobody hear you. I said,
Yeah.
that's it. And he's like, okay, I get it. And it was the best
You
thing.
know what it's like. The kids grow up,
They go away.
move to Scarsdale.
I don't know whose kids those are, but
No, I moved to, North Carolina,
But still,
But it's,
No.
yeah, but it's the same, right?
yeah.
And who is it? It's always the 14-year-old daughter from upstairs.
yeah,
Some-
I'll never
someone's
forget,
kid, yeah.
comes from upstairs, who comes down and helps with the shopping or helps with whoever.
yep, yep. That's why it's
And
always
it was
good
that-
to,
it
it's
was
always
that
so
one
good
day.
to have somebody else give a key,
It's that
Yeah.
way now.
just in case. I even, at times when I lived in Manhattan for a short amount of time, I always made friends with somebody and we shared give keys, just in case of emergency.
Mhm.
I don't want somebody to be banging the door down or whatever, God forbid, something happens. So
Right.
it's always a good thing. I mean, I do it now, with friends, but
So colon cancer is only a little piece of it.
Yeah,
And it's
but,
interesting,
because
yeah.
of my husband and my son, so I'm aware
yeah,
of, what happened, but his was caught and
Oh, God.
he was fine.
Okay.
But then many years later, esophageal cancer and his no symptoms, because you could have it in one place or down here. And in one place, he had no symptoms, no GERD, nothing.
yeah. And you said about frailty. Now, the one thing that stood out with me, when you go every 3 years, you go for your defensive driving, okay? Every 3 years, so you
Yeah.
get your discount. And every year there's something new, but the one thing that was new that stuck out is that a high percentage of accidents happening to seniors when they're driving. And I said, well, how is that? Well, you have somebody in the passenger seat, you have the wheel in front of you, but that person is gonna hit well, the window or whatever, and whatever, even if they have, they have their,
Seatbelt
seatbelts on or whatever. But even the seatbelt causes bone frailties and everything. I went home that day and I said, Mom, you tell me one more time you don't put on that seatbelt, you're not driving in the car. That's it. I had no idea, and I've been driving for a long time. And the frailty is a big thing that people don't think about it.
And also with infants, you don't think with, in the car seat, my friend was telling me she has a new grandchild. And she goes, they don't like the children, the infants or the young babies, to be in their snowsuits or whatever. You warm up the car before you put the child in. But you don't put this snowsuit on them.
Yeah.
For whatever reason, they say you just maybe put a blanket or whatever.
Right.
And I mean, forget about it. I mean, my kids, everything changes.
Yeah, they do change. So you're always glad over the years that everybody gets out of it safe.
But I will let John know that
Yes, please.
for your presentation, and I will, because we're working on it, and I'll ask him, I hope you can get Dr. Coulter to, even have a table there with information.
Yep.
And
Yeah, even I didn't know 45 was the age, so that's whoa.
Yeah,
this is
you're
not-
getting close
I
to
am
it.
getting close. You can tell folks, like, hey, this is the age,
Yeah.
you can get this done, this
This is your options.
Yeah, exactly, so thank you.
Thank you
No,
so
no, the
much.
other part is that, if you don't have a dock,
Mm.
go to Jacoby.
Yeah, no,
I mean,
Clinic, it's great.
and if you don't have a lot of money, well, then they'll charge you $2,
I had,
Yeah.
when Ray passed, and then all of a sudden one time, I had pain in my back, and I really thought I was having a heart attack. And someone drove me straight to Jacoby Emergency, and because I was older, and they said, gotta listen, especially to a woman, they could have a heart attack, and it would be in the back. But it turned out to be, I had kidney stones.
Really? Wow. See, it's amazing. Pain is a sign.
But they would, I would get priority, and they have like a geriatric, yeah,
Yeah.
and it was
Yeah, my
wonderful.
mom was in, for 2 weeks in the ICU at Jacoby, and they did great.
Okay.
all right, thank you.
Thank you. Yeah, do we have to thank
Thank you for
Jeremy?
inviting me.
Yeah,
Oh, thank you for coming.
I think
Here that way.
that way, you.
That way, that one.
I'm close, yeah.
Just make sure that you close the door,
Right.
because it still gets a little stuck. But send to Jeremy.
Yeah,
And we'll let the board know to watch this presentation over there. And thank you.
thank you so much.
You should stay connected to maybe to do
Yeah, I
something
will.
for outreach. I mean,
I will send you an email. With, why I always send thank you, and then I'll remind you about the health fair.
yep,
But,
and
Thank
the
you.
Good to
outreach.
meet you. Thank you
Thank
so
you
much.
so much. Bye-bye.
Thank you. Okay.
Yeah, John will be happy, because he was supposed to come last week and something.
So what
But how
about,
old, I have no idea.
so did that person call you? Did you check your phone
No.
at all?
Well, not now, and I didn't get it. But sometimes it happens. I will, say, sorry, we missed you, but I have someone coming from out of house.
Okay.
Well, because for 20 years, my husband worked in Foster Care.
Well, just,
He was a,
I'm gonna just double check, by the way.
oh, wait a minute, he's a missed call. Let's see who this is. I have no idea. Because he was director of childcare at a foster care agent. Come on.
Okay, did you want to open up to the gallery session?
Well, I don't think there's anybody else. Oh, Cynthia,
I,
oh,
so, yes. Now we got,
oh,
yes,
Cynthia, we're putting you down for remote.
Cynthia and
Serena.
Serena.
Mhm. Okay.
It's the phone, is it? I don't know who this is. I have a 917 number. Didn't even leave a message, so I don't know if that's the doctor.
Did you want to call?
I'll do it when I get home. Let me see if I have. Then there was something else. Kids always laugh at me because I can't. They go, "You gotta touch it." It never works for me.
You guys, just to remember, you got to put your initials.
Yep, let me get that.
Sorry, I don't mean to interrupt. I just got put it off.
Okay, no
All
worries.
right, we're
I
finished.
think we're good.
But it was really a good.
It was a really good one, yeah.
He was very good. He was.
Thank you. I listened to the last half hour. Sorry for all the noise.
You know, what he did and what I liked, Cynthia, is that when he spoke in a way that we understood. He didn't use all of the, medical mumbo jumbo that some of them throw out. And it was understandable and good.
So,
So thank you.
that presentation will also go to Jeremy and get sent out to everybody, because just basically the understanding that what's been preventative the last 30 years or whatever, it's actually worked out.
Yeah.
So it's definitely the direction to keep going and to improve on. But the outreach and the education is very important, and it's also helping people make a decision about it, because it is still a choice.
Yeah.
Yeah,
So, and that comes with education, and also if people have fears about it, all of that, comes under the education and question, Q&As, and maybe having people that have gone through a colonoscopy, what they have to do
the prep,
beforehand.
yes. And
That's important.
yeah, and now a lot of them no longer have to drink at like
A
gallons.
gallon of water.
They don't have to. There
Yeah.
are some other ways which I found, because I could never do it.
My sister-in-law, went through
I
that.
couldn't. I'm just not a drinker.
Yeah, it's just too much.
It's
Well,
too
it's
much.
like-
I get sick.
Yeah.
It doesn't go down.
Yeah.
It doesn't go
I-
down.
this must
I'm
be
there. And my husband, my favorite drink. I feel there's nothing.
So is
You
there,
understand?
there's no motions,
No.
because we don't have a quorum.
No, old business is the health fair. And Cynthia, are you still there? Well, I want to thank her. Whenever she goes to a health fair, she'll give someone the information and get in touch. And I have to get in touch. I have to look at Serena now, not as on the health committee, but for the group that she works for,
Right.
the community health. So
Do we have a date for the?
June,
There we go, just for the people that know.
June 23rd.
June 23rd, there we go.
And it's on the Facebook page or something, Friends of, or I don't know, whatever.
I don't know if is there
I don't
a flyer
see
out? Is there a?
There is a flyer on one of the, I think it's the Facebook. I don't do any of that, although,
Whatever it is, maybe, I haven't seen it. It should sort of like, at the
Yeah.
beginning of the month be pinned to the top or something.
I don't know,
Each
but
month.
maybe I'll ask Cynthia again, because she did the thing and she did a very broad one.
Okay,
But now we could list some of the people
Yeah.
or groups that are there. So I'll have to,
work
get
it.
in touch with her, work on it.
Put your initials here, would you? Initials. Thank you.
So that's it.
Okay.
All right, and then I'll speak to Dr.
So,
Modella.
yeah, the old
But
business,
next month,
the old business is the health fair.
they'll
And
fair.
also, I mean, what would be really good is really trying to set up, even if it's once or twice on the weekend, on a Saturday or whatever, at Eastchester Gardens, or, and ask Keith to help with maybe some of the people he knows in the different buildings, and start to set up and find, I mean,
No, and not Keith so much, but I think Angel does a lot of that.
no, I know, but Keith, Keith that's his area.
Yeah, but next month I have someone from Rabbit House.
Okay.
And that was a thing because, as I said, for more than 20 years. In fact, I had, when my kids were young, because he was director of
Okay.
childcare at the agency buildings. I
Okay.
even had my own apartment there, but we didn't stay over. And I have autism.
Mhm.
And then in June, Alzheimer's and brain awareness, and that is,
Yeah, my, I
And then
mean,
that-
just,
that-
you know,
so,
my
we're
younger,
trying,
my younger brother is severely autistic. He's in a group home up by Mount St. Michael for, since he was 24, he's 58. And, you know, I did it in my psychology class. I did a paper on autism years ago where there was no resources. So, you know, it's amazing now how far they've
Yes.
come so that they can see the spectrum.
Well,
It's amazing.
I knew someone because I was on the board of visitors at Bronx Site, and we would meet and from all over the state, all of the members. And one of the members from upstate, they had 4 children. 2 of them were like geniuses, and 2 of them gave them ajna.
Mhm.
You know,
Ajna.
ajna. And they couldn't understand one, but the kid was bright, but like Alan. Finally, and this was very early on, he had Asperger's. Once they knew that,
What?
it changed
Yeah.
everything.
Because they knew how to handle
They
it.
They let it.
Yeah.
But he said they went from doctor for years, for years.
Interesting.
Mhm.
But we're talking more than
Yeah.
20, 30
Yeah.
years ago now.
Now you can tell, you know, you
Yeah.
can have a test.
But he said, what a difference
Yeah.
having that diagnosis
Well,
meant
or-
and the help. And I mean, they were, in the field. All righty, my dear. I'm
All
ready
right,
to go.
so,
And Richard.
Yeah, no, anytime.
make a motion to adjourn?
Yeah, motion to adjourn.
Second.
On favor? Aye.
Okay.
Now where's Jeremy? to say-
Jeremy, we're gonna log off.
Jeremy, where are you?
8:12.
Sandy, I got you. Oh, she heard me talk
No,
about it.
yeah, good night.
Okay, Serena, I don't know if you could still hear us.
I'll call Jeremy.
Okay, I got it, I got
You
it.
got it, okay? All right.
I'll text them that,
Oh, it's like an open mic, you gotta be.
Oh, yeah, right. I'm gonna disconnect. Okay. Oh, because he's still recording.
Oh, God.
No, we're good though.
well, I'll call.
Yeah, okay.
I don't really go on Facebook, but someone saw me today and she goes, I saw your pictures.
Oh,
And I go, saw my pictures? She goes, well, someone sent you something because,
the helper?
no, it
Oh.
had to do with my husband's dearest friend lost his second wife and I could not go to the funeral. I could not drive to Long Beach. But, my son, he took the day off yesterday and he said, let's take Marty out to lunch. Let's
Oh,
do this. And because his kids, they were in the play.
yeah.
And Marty and my husband were in the carriages together with their mothers.
Oh, wow.
And he'll still call up on my husband's birthday. How you doing, Sandy? Whatever. So,
Yeah.
we went out there, but we had the eclipse.
Okay.
So his daughter was posting pictures.
Oh,
Someone says, I
I saw you in the back of a picture.
saw my, because I don't know who. They must have sent to me something, but I don't do Facebook and